Okay, good morning, everybody. Thank you for joining us for Grand Rounds. Really excited to both welcome you on Dr. Leonard's behalf, but also to introduce today's speaker, which I will get to shortly. First, the standard announcements about CME. You can text the code there, and that will be put in the chat box for you. And upcoming Grand Rounds, we have our own Shelley Josephs, who will give an overview of all the incredibly cool things they're doing in pediatric interventional radiology next week. And then we will have our recurring series, our quality improvement series, the following Friday with Lane Donnelly, Learning from Systems Failures. You can get the next slide. A few other upcoming events. The abstract deadline for our 12th annual Pediatrics Research Retreat is due today. So get those abstracts in after you listen to this talk, of course. That's a great event. So please do submit, or at least encourage your trainees to submit as well. There's a QR code there to visit the website. Next slide. Our COVID in Children weekly seminar series, that is going to be a fun one next week. We're going to hear about some kind of other organs that are involved, dermatologic manifestations. We'll talk about anosmia and dysgeusia. Then we'll talk about the indirect impact on the developing eye in terms of all of the screen time that kids are getting. So that is some great speakers from outside of the department for that talk on the 21st. And then next slide is today's talk. So I am really thrilled to introduce Dr. Sean Ralston. Shawn is a friend and a colleague. She is currently the Chief Quality Officer at Johns Hopkins, where she is an Associate Professor of Pediatrics in the Division of Pediatric Hospital Medicine. And in thinking about Shawn's incredible career, I'm hard-pressed to think of someone who has contributed more to the field, to the growth of the field of pediatric hospital medicine. You'll hear about the VIP network, which I think is really one of the field's crowning achievements. And Shawn was instrumental in the origins and continued success of that endeavor. But Shawn has many other contributions as well. And if you look at her slide, at her video right now, right to my right of her head, you can see a framed picture of the first ever issue of Hospital Pediatrics, an AAP journal that at which Shawn is the editor-in-chief. It's really been a fun journal to see grow and contribute to the science of the field. Shawn was the chair of the AAP's Bronchiolitis Guidelines Committee. Those were notable in that they really were a departure from prior guidelines and challenged us to provide high-value care in bronchiolitis. Shawn, as we will hear today, started the VIP network and then has really been a champion for mentorship, for the growth of junior faculty and trainees in our field, and also a champion for gender equity. We all wonder if Shawn ever sleeps because she does so many interesting and cool things. But as a testimony to her well-roundedness, I will sometimes ask Shawn for book recommendations, and she'll tell me about the top 2 books of the 5 that she has read that week. And if you can just go to the next slide, Ingrid. And if you don't believe me on this, she was actually on Jeopardy, where she really had quite a showing here. I think the guy in the middle there, Jason Momoa from Aquaman, Shawn, because anyway, you really kind of beat him pretty handily. And then a nod to Alex Trebek, of course, who we will miss dearly. So Shawn really is a jack of all trades and an incredible leader in our field, and so grateful to have her here today to talk about the value in Pediatrics Network.
Thank you so much, Alan, for that introduction. I had no idea he was going to do the Jeopardy thing, and and that was a little embarrassing. Okay, cool. So the most interesting thing about Jeopardy, I'll tell you before we get started, is what you don't see is that behind the scenes there, we're all standing on little platforms so that everyone looks like they're the same height. And what was fascinating is the guy that won, the guy in the red tie, that guy was about 5 feet tall. And the guy that looked like Jason Momoa was about 6'6". And, and so every time you get a break, you fall off of the platform because the guy next to you is 6'6". So anyway, that was probably the most terrifying experience of my life. And I never, ever want to do anything like that again. So thank you again for tuning in for this Grand Rounds. I get to talk about something that's a huge passion for me, and something I'm just of when anybody ever asks, like, what are the favorite things that you've done in a career in hospital medicine? This is always, you know, the top two. The other one being the picture of the journal that I intentionally positioned my laptop so you could see. So those are the two things that are my favorites. I am going to see if I can advance my slides. I apologize, I'm having a little bit of trouble there. Okay, had to just make my slides live again. So I have no financial disclosures and no conflicts of interest. This will become pretty obvious as we go through this, because I'm mostly going to talk to you about how I've spent the last 20 years trying to get people to stop doing stuff. The objectives here are to describe this network. You know, in particular, I think this network has a lot to say to the community of pediatrics about doing quality improvement, inpatient quality improvement, and some of the things that are really unique to pediatrics and important, and how we interact with adult hospitals and how we interact, you know, in general in the community of academic pediatrics. I'm going to discuss some barriers to doing QI, specifically in the non-freestanding children's hospital setting. And I hope that I will make the case to you that it's important to you even in the freestanding hospital setting. And then I'm going to talk a little bit at the end about the current limitations of quality measurement in pediatrics and why I think that matters as well to us making progress. This is the slide, an impact slide that we made for the network itself. And this is sort of jumping ahead. I'm going to talk about each of these projects a little more in depth, and I'm going to talk a lot more about the network. But I just wanted to give us a sense of sort of what we're about and what we're doing. And I think that you can see that the things that we're prioritizing are, you know, avoiding unnecessary care in children. So I'm going to lead this off with the who, what, why, where of the network, but I'm going to do it backwards. And I'm going to start with the why. You know, so why do we care about overuse in pediatrics? So I'm assuming that most of you already have an understanding that waste and unnecessary care are important topics in healthcare. I certainly know this is Alan's wheelhouse, and one of the topics I've heard him speak on in so many different venues that he does so well. So I intentionally took out my slides on you know, the global problems in the U.S. with healthcare waste and overuse. And I'm going to jump right in to try to convince you that it's still important, even though you're a pediatrician. And you may have previously thought yourself slightly exempt from some of it, but it turns out that we're not. You know, healthcare spending for children is equivalent to half of the defense budget. Yeah, I think we all agree that the defense budget is quite a large amount of money. This was one of my favorite observations that anyone has made, you know, nationally about children's healthcare quality and spending. This is from Kaoping Chua, who I'm a huge admirer of in JAMA in 2018, and I highly encourage everyone to sort of take a look at that commentary. So that's why children's healthcare. Why hospital care? Well, of course, I'm a hospitalist, but also because hospital care accounts for about half of pediatric healthcare expenditures. So, you know, while the larger proportion of pediatric healthcare is done in an outpatient basis, you know, we're the ones wasting the money in the inpatient side. Also, the reason it matters is that inpatient healthcare comprises a greater proportion of healthcare costs for children than for adults. And we also have mistaken assumptions about where this care is provided. And I'm going to get into that a little bit more clearly. So something that that has always struck me, you know, in 20 years of academic medicine is, you know, that we are dominated, you know, in the academic conversation by freestanding children's hospitals. And that's great because they do terrific work and they, you know, really are advancing the field. But unfortunately, some of that work doesn't get out to the area where most of the care is being delivered to children. So I worked with a friend, Joanna Lyonar, who's at Dartmouth, and I used to be at Dartmouth, and we wanted to answer the question of, just exactly how is care proportionally delivered in the U.S. So freestanding children's hospitals are, freestanding children's hospitals, who are essentially administratively independent. And then there are certainly many community hospitals that provide children's care. So a dedicated ward for children. And then there's this hybrid of a children's hospital within a larger adult system. And each of those are somewhat complicated. And we sought to tease out sort of some understanding about volumes. And these are the results from that study, which used the KID, the HCUP database, which is intended to be a proportional look at children's hospitalizations across the United States. And I just want to highlight two of the most important observations from this study. One is that of children's hospitalizations in the United States, about almost 3 times the number occur in hospitals that would count as general hospitals. So these are the community hospitals with a pediatric ward, or the children's hospitals within a larger hospital. Whereas, in the 50 freestanding children's hospitals that were available, at the time of this study, only about 30% of hospitalizations for children occurred there. But then I want you to notice, what those hospitalizations look like. And I highlighted the median number of hospitalizations in each of those settings. You can see in children's hospitals, it's 12,000 hospitalizations, is the median yearly hospitalization. Whereas in the general hospitals, it's 56. So there is a tremendous distribution of volume across the what qualifies as a general hospital. Whereas, with many of these hospitals hospitalizing very few children a year. What are children hospitalized for? And this is from the same study. And these are the most common conditions in general hospitals and children's hospitals. You can see in general hospitals, it's pneumonia, bronchiolitis, and asthma. And in children's hospitals, it's asthma, bronchiolitis, and pneumonia. I would argue that the order of those are probably more a function of coding than the actual incidence of disease, but it's the same thing, which is kind of remarkable. So despite the unequal distribution of volume, the diagnoses are the same, which is interesting and helpful. So who is this network? Well, this is a picture from our very first in-person meeting back so many years ago when we actually used to have in-person meetings for things. And mostly, and this is a bunch of hospitalists is what this is, meeting in a restaurant in Tampa, Florida, and getting together to sort of form this network. A couple of these guys have gone on to do really great things, become presidents of hospitals, and then a few of the rest of us are still hanging out doing the same thing we were doing 12 or 13 years ago. So let's get a little more into the details of the network itself. What were the guiding principles of the network? Well, as a hospitalist QI network, we wanted to work on common conditions. I don't think that's groundbreaking. Overuse measures were one of our major interests. And we felt at the time, this was back in 2008, 2009, that there just wasn't a lot of attention on overuse in pediatrics. And yet hospitalists were really talking a lot about this as a problem that, that affected their day-to-day job satisfaction. We wanted to work on quality measures where the provider actually has control over the measure. This was another frustration for hospitalists, where some of the QI in their hospitals seemed to be directed to things they really didn't feel engaged with or have direct control over. A really big motivator for us was we wanted to work everywhere, including these community hospitals and children's hospitals within hospitals. That was a major motivator. And most of the people in that picture I just showed were working in the children's hospital within a hospital setting and not in a freestanding children's hospital. We also wanted to facilitate the spread of what we were doing by trying to publish, and we wanted to build capacity in the field of pediatric hospital medicine. This was always a major motivator for us. So before I get to the work, I just want to take a minute and make a little bit of a joke. I picked out this cartoon very specifically for Alan. Because, so here you have the mom bending over for the little boy who's fallen off his bicycle, and she says, "Let me kiss it to make it all better." And then the doctor is running down the road saying, "Don't listen, it's no better than a placebo." This is a little bit of a joke, but also to allow me to make the point that despite the fact that this being a QI network, what we were very specifically engaged with was the idea of translating evidence-based medicine, from places like the freestanding children's hospital into the community and the children's hospital within a larger hospital. So evidence-based medicine was always a major driver of this work. This is our very first project. This project took 5 years to organize and do. This was a volunteer project that actually happened mostly around kitchen tables and the occasional in-person meeting. This project we called Benchmarking Bronchiolitis. And specifically, the reason we coalesced around bronchiolitis as pediatric hospitalists were there was a lot of peer group frustration, with this disease. It's a high volume, high utilization disease at the time. And we had a national guideline, to back up all of the things we thought we should be doing. But we all coalesced around, pardon me, my office phone just rang. We all coalesced around the idea that we weren't really, translating this evidence-based management into our own clinical settings. In this particular case, each hospital received a benchmark report, which benchmarked their own yearly performance against the overall network performance. And the basics of this were that we gave individual help for people to roll out an evidence-based management plan for bronchiolitis and encouraged anyone to join. There were no barriers at all. Most of the people shared local resources across the network. And, we really were just a group of people who were sort of loosely affiliated around the desire to benchmark our performance against each other. And as I'll show you in the next slide, we were able to move the needle a little bit on bronchodilators and chest physiotherapy. I'm sure that there are some of you on this Zoom that probably don't even remember chest physiotherapy as a thing. And that's wonderful because it's a highly non-evidence-based practice for acute viral bronchiolitis. But at the time that this network was forming, it was still a thing. So here's just a little snapshot of what the network looked like. We had 17 hospitals that were able to participate over the full 5-year period. There's a year of formation and then each of these 4 years of reporting. And this feels like such a long time ago now, but the last year is really only a decade ago. And what this is the each hospital's benchmark use of any bronchodilator for their inpatient bronchiolitis patients. The reason I include this relatively sort of unsophisticated presentation of this data is I didn't want everybody to take a look at the fact that most people were using bronchodilators in these amazingly high rates. Almost every single site was using bronchodilators in more than 50% of their inpatients at the time the network formed. The asterisk were just the two of the 17 sites that really didn't make any improvement over the course of the 5-year project, which 2 out of 17 is pretty good, I would argue. The next slide is the volume of bronchodilators. And the only reason I put this in here, is just so that people understand that what this represents is the total, the average doses per patient admitted for bronchodilators. So, our worst performing site when we started was giving an average of 16 doses of bronchodilator per patient for their admitted bronchiolitis patients. And I still sort of marvel at that. It's a phenomenal, change over time. And you can see in this particular case, this was a measure that we had actually quite a bit more improvement on than just the general overall use of bronchodilator. People started using a lot less bronchodilators. The 2 sites that did not get better actually were already some of our lowest utilization sites. So in general, we were excited about the engagement of 17 hospitals in a desire, to improve for no reason other than that they just wanted to do the right thing. There was no external support for this. There was no, there really wasn't even expectation of publication when we formed in this. And I think we look back on this, and I used Homer Simpson here because I think we probably didn't understand that we could really build something with a disseminable academic product based on this. We were just getting together to do the right thing. Our only hypothesis was that if we got together in a group, we would create a social norm around evidence-based medicine and bronchiolitis, and maybe things would get better. We did not do other things that we would come to learn as a network were important. We made no attempt to control for temporal trends. Were things getting better, or was the benchmarking the thing that really was moving things? And it took us 5 years to do this. This is an unfunded volunteer project with no external resources. But because we were able actually to do it, and because we were able to publish on it, it gave us the opportunity to level up a bit. And to go on to another project. In order to do this, we were lucky enough to get the sponsorship of the AAP for some administrative support for this. And so this is just a snapshot of what the growth of the network looked like after that first benchmarking project. These are the names of some of the projects, and I'm going to talk about each of these specifically in the next few slides. But the next project, from 17 hospitals, we got 21 hospitals, and then we grew sort of, really, aggressively over the next decade. Some of the early projects were actually limited by resource availability, so we weren't able to take all of the hospitals that applied to the project. By the time we hit our febrile infant project, we were able to take all the projects that applied, and we were routinely enrolling over 100 hospitals in each of the projects. So this is our first real project. Our first project where we had actual staff at the AAP. We had an actual website. We had webinars. This really was this is our break into the big time. And of course, it was bronchiolitis. It was bronchiolitis because we still, didn't feel like we had gotten anywhere near, to evidence-based practice based on our experience with benchmarking. And we wanted to actually begin to become a real quality improvement network where we tried to use quality improvement methods much more clearly, and use quality improvement analytic methods for the results, and so that we could do a better job of controlling for secular trends. This project was called BQIP, which we liked the sound of BQIP, but the name of the project was Bronchiolitis Quality Improvement Project, which I've inserted the joke there that that's kind of a genius title, and of course not. But it's become something of a joke that we have to have a catchy acronym to do a project. This project enrolled 21 hospitals, and the measures you can see there were bronchodilators, of course, corticosteroid use, chest radiography use, respiratory score use, which we promoted as a positive, and I'm going to talk a little more about how that worked out, and pulse oximetry limitation, and tobacco smoke exposure screening and referral, which is another thing that we've tried to do longitudinally, is promote pediatrician involvement in smoking cessation advice for parents of children, because most of our hospitalizations and most of our work has been around respiratory illness. So these are the results from BQIP, and on our primary outcome measures. This is each institutional each institutional performance, and then a box plot of median and the interquartile range, and to read this chart, focus on 0. 0 would mean that there was no change from baseline on the measure for each of the institutions. And so the direction of improvement is down. So what you want to see is decrease in utilization of each of these things from baseline. So every black dot that's below 0 means the place got better, and every black dot above means they got worse, technically. Now, this isn't entirely statistical in terms of getting worse, but their performance did not improve for sure. In general, you can see that the median performance improves, across the board for bronchodilator use, bronchodilator doses, steroid use, steroid doses, and chest radiography. And for the most part, this project we felt was a pretty resounding success. We went on to try to learn from this project in that we did qualitative interviews and some quantitative assessments of performance benchmarked against characteristics of the sites. And here's what we came away with. And we do this a lot. And this is, you're gonna see this sort of, what did we learn from the project? I think we do a lot of QI and we expect a certain amount of general improvement in the measure, but what we're always trying to do is figure out what we did right and what we did wrong. So from our BQIP mixed methods, assessment, the only thing that was associated with better performance from any of our objective measures or quasi-objective measures was a self-reported measure of team engagement. And this is sort of numerical scale and also size of the team and those types of things. So, the more people that got excited about this, the more likely people were to actually reduce their overuse of these measures. One of the big things that came out, and this, is something that really drives us, is that regardless of how people did, everybody said intra-institutional competition for limited resources was a big deal. That adult priorities in children's hospitals within hospitals and in community sites were always given resources first, and pediatric priorities were sort of left begging for the scraps. And this comes up again and again in the non-freestanding children's hospital environment. Participants in BQIP also sort of emphasized their difficulty in managing care across the continuum. And this is what we started calling the blame it on the ED excuse. Believe me, I'm not here to criticize the ED, and I'm gonna call out ED improvement and performance and engagement in our projects as we go on. But in the beginning, people were like, well, the ED is doing it, so how can we change? We took this as a challenge, actually. And I'll talk a little more about that. I mentioned the scoring, as one of our big assumptions, and based on the existing literature at the time, we actually really thought that respiratory scoring was a driver, for QI. And a lot of this came from Cincinnati, and our colleagues at Cincinnati participated with us, in an assessment of they allowed us to promote their respiratory score, which is called the WARM score. And they participated with us in an assessment of whether the WARM score, at the local hospital level, and, we had patient level data to some degree, drove any decrease in bronchodilator use, because this was a hypothesis that seemed reasonable at the time. This is the paper that we published on that. And unfortunately, it turned out that this didn't turn out to be true. It feels like the respiratory scoring is necessary or is a QI driver, but we could not establish that respiratory scoring actually truly resulted in a decrease in bronchodilator use. And I think this is really interesting, right? Because at the time that we did the work, not at the time the paper's published, the AAP guideline said that you could have a trial of bronchodilators, but you needed to do an objective assessment of improvement. Well, what were people using as an objective assessment for improvement? People were using respiratory scores, assuming that they were an objective assessment of improvement. And this has been a very difficult to substantiate claim, and I'm not sure it's true, So based on, after that, we moved on to the next diagnosis in the list of diagnoses that were important for pediatrics, and this was community-acquired pneumonia. So our next project was called Icap, Improving Community-Acquired Pneumonia, obviously chosen because Icap sounds cool. And the goal here was to comply with the relatively recently published at that time, Infectious Disease Society of America Community-Acquired Pneumonia Guidelines, which recommended narrow spectrum antibiotics rather than broad spectrum antibiotics for community-acquired pneumonia. So that was our primary interest and primary measure. Some secondary interests were to reduce the usage of macrolides. and to also consider reducing the concurrent treatment of asthma, primary asthma patients as pneumonia. And then we had some secondary measures around labs and x-rays. So this is the same type of chart that I showed you for BQIP for Icap, where you get to look at individual site performance and then overlaid on top of overall network performance. And in this project, we took to heart the fact that the ED really was the site of some of the initiation of care, and we engaged the ED a little bit better than we had done in the first project. We had we measured ED performance, we recruited some ED members, but we didn't do a terrific job of this, and I'll talk a little bit about that over time. So, but this is our ED performance, inpatient performance, and then performance at discharge. And again, if you look at this chart, 0 means no change, and the direction of preferred change is an increase, and this would be an increase in the prescribing of narrow spectrum antibiotics in community-acquired pneumonia. And what we wanted to see is most of the dots above the 0. And in general, again, this project, was managed to be relatively successful. This is a measure, quick view of how we did on decreasing macrolide use in community-acquired pneumonia. And I'm not going to spend a lot of time on explaining the method of analysis, but what you've got here, cycles 1, 2, and 3 are our baseline data before the intervention, and cycles 3, 4, 5, and 6 are after the intervention. And anything below this lower control limit here signifies a significant change, and you can see that in both the emergency department and in the inpatient setting, we did have some amount of decrease in macrolide use with this project as well. This was our attempt to learn from this project, some qualitative interviews with people who participated, and to try to create a framework and understand a little more about how, how QI specifically in the children's hospital within a hospital or community hospital setting fits into some of the other theories around change in these settings. Next project, called Stewardship in Stewardship and Improvement in Bronchiolitis, SIB, because it was a sibling of BQIP. Yeah, so obviously super clever. The goal in this project, was to continue to try to engage with the ED specifically around bronchiolitis care. This project enrolled 35 hospitals, and an ED team was required to enroll in this one. So we continue to try to learn and engage the ED in similar measures. You will notice that chest physiotherapy, is no longer a part of our work, and the respiratory scoring is no longer a part of our bronchiolitis work, because one, chest physiotherapy was essentially now occurring at a rate that was impossible to measure, and because we no longer really felt completely wedded to respiratory scores in bronchiolitis, having been unable to substantiate that they were a big part of the improvement. So these are the results the main results from SIB. This is our bronchodilator measure, and now you can see that this is our inpatient, this is our emergency department on the left and inpatient on the right, and the primary measure on percent of patients receiving any bronchodilator. The baseline period and improvement period are indicated. And what you'll notice here, or what I want you to notice, is that ultimate end of project, performance of the overall group between the emergency department and the ED were really not all that different. Around 20% of patients, were where people could get around 20% of patients receiving bronchodilators. And I think this was kind of amazing. This work was published in 2018. But it was done, beginning in 16, 17, and I think this was a big revelation, I think, for a lot of our emergency departments, where they, there was still a prevailing feeling that you were going to pry bronchodilators out of their cold dead hands, and the majority of these hospitals were able to achieve performance that was, pretty terrific by the end of this project. At this point, we actually did our first multi-project paper, where we combined the tobacco work in SIB and BQIP, to look at how well we did on screening patients for tobacco exposure and actual referral to treatment. We wanted to focus on referral to treatment. Because I need to talk about quite a bit more, I'm not going to go into this project, but ultimately, at this point, we had done and published several projects, and we're feeling pretty good, and felt it was time for growth and the next level up. So the next level up was to actually engage with everybody who wanted to join a project. At the time that we launched this project, which is called Revise, and it's reducing variability in the infant sepsis evaluation, we thought a couple things. Our largest project to date had been 50 hospitals. So we thought, we'll get a little more than 50 hospitals, one. And two, we actually thought the AAP was going to publish a febrile infant guideline that was going to be pretty close to the time of this project. So neither of those assumptions turned out to be true. We ended up enrolling, we actually ended up enrolling more than 130 hospitals, and 124 finished the project, which was truly astonishing. And unfortunately, the AAP did not publish the guideline, due to some conflicts over the content of the guideline. So we had to, come up with our own measures, which was quite a challenge. This was the first time we approached a composite quality improvement measure. And this project's composite quality improvement measures were defined as appropriate evaluation criteria for the febrile infant in the emergency department and appropriate length of stay in the admitted cohort. I'm going to skip straight to the results in the interest of finishing this talk. So this is our statistical process control for both of the composite measures for this project. On the left is the appropriate hospitalization, and on the right is the appropriate length of stay criteria. And so you can see that we had a modest improvement, in number of sites meeting both of these criteria. What I want to point out about this is that we had a sort of shift in our thinking, in that we were finding it a little difficult to motivate people to reduce overuse. And not difficult. I mean, we were being successful, but we were feeling that we weren't as successful as we could be. So we began to try to frame some of our overuse work, in a more positive manner. So that was the reason for the choice of appropriate hospitalization and appropriate length of stay criteria. Ultimately, appropriate hospitalization and length of stay criteria were around, the prolonged length of stay that was felt to be unnecessary sometimes in these patients, and some workup that was felt to be unnecessary. So I just want to make the point that that the spirit of the network was the same, and the framing of the measures is what was changing. This was how we chose. This is a new way we chose to present the performance of all of our the sites. Anytime you're doing multi-center QI, you're often presenting an aggregate outcome, but you also really want people to understand whether most of your sites are getting better, or or if the performance is only being driven by the sites that were really bad off to begin with, or to give a better picture of this. And so each of the dots is an individual site. And what you'll see, the area of improvement is the white area, and an area of deterioration is the left area. So this is just a little different way of showing how each of the sites do. And what you want to see is most of the sites, in the white area. We also noticed that the volume seemed to be a driver in terms of if you actually were evaluating more infants, you were likely to be able to improve care, as opposed to the lower volume sites, where improvement is, because the infants were fewer and far between, it's a little harder to change behavior. And I think that goes back to our interest in understanding QI, where the care is delivered, and the low volume sites, and how is QI harder in low volume sites than in high volume sites sometimes. Another interesting thing that we did with Revise is the first time we used an app. We partnered with some folks at Children's Mercy in Kansas City and developed an app. And this is just a screenshot of what the app looks like. And so, this is a paper of evaluation of the impact of the app on this project. Again, always trying to think about ways that we can get better, and ways that we can both advance the impact, spreading quality improvement, to all of the sites where care is delivered to children, but also getting more academic and more rigorous as we grew. And which leads me to Pipa, which is Performance Improvement in Pediatric Asthma. And this was our first project that was actually run by a grant-supported investigator. You know, this was run by Suni Kaiser from UCSF, and as part of her K award. So this project was significantly more rigorous in terms of its evaluation plan and study design, but ultimately, you know, had the same structure in terms of being very focused on recruiting community hospitals and being, you know, run by a volunteer group of experts for the most part. The measures in Pipa were, there were some composite and some specific, and I'm not going to go into too much detail on this one because it's also broken up into inpatient and ED, and there are still several papers that are in press from this project. But I want to point out some of the successes of Pipa. This is the inpatient Pipa, and this is an interrupted time series analysis, which was the first time we had gone, we'd used interrupted time series in our analysis. You know, statistical process control, you know, sort of the mainstay of QI, but in the setting of multi-center QI, you know, I think it can be sometimes a little difficult to argue that that a single SPC chart, you know, combining those outcomes, you know, is the best way to analyze. So we, you know, we leveled up on that point with analysis, thanks to SUNY. And in this particular case, the major measures I'd point out were the use of MDI inpatient, which is the one I've circled. And then below that is the screening and referral to tobacco for inpatient asthmatics. And those are the ones that we had some real successes with in this particular paper. On the emergency department side, you know, some successes with scoring and with decreasing admission rates when patients were funneled into a pathway more quickly in the emergency department. This is again this site performance, and hopefully you remember the scatter plot from Revise. And we learned that if you label your area of improvement green, people will understand that it's the area of improvement. That's a little bit of a joke. But where you want to see is most of your sites in the area of improvement. And where we saw that was, of course, on the MDI measure, you know, transition use of MDI and transition to MDI, as well as referral to tobacco cessation. You know, so those were our big successes with that particular project. You know, and again, we you know, continue to learn and continue to want to be more rigorous in our evaluation to be sure that what we're doing, you know, as a QI network is really what's making things better. And so the next project, this was, you know, a project where we began to think about study design. This one is called Standardization of Fluids, or SOFI. And this project was linked with the AAP guideline on maintenance IV fluids, recommending isotonic maintenance IV fluids. And what was different about SOFI is this project was a stepped wedge design. So each hospital got randomized to one of three groups, which would start the project at different times so that we could more rigorously evaluate the impact of our interventions on the outcomes. This project is not published yet, but it, you know, 106 hospital sites completed the project, and our measures were the number of days on isotonic fluid and number of hours on isotonic fluid, as well as a secondary interest in decreasing laboratory monitoring when patients were on IV fluids. This is just a quick snapshot of the preliminary results. And what you'll see here in the first period, you know, is our baseline data. And the first red line is the publication of the AAP IV fluid guideline. And you can see that in general, that guideline had a fairly significant immediate impact. This time period is here in the middle is also when people were enrolling in SOFI and getting ready for the project. And the red line is the intervention period, which did, you know, have a statistically significant, you know, impact on increasing the use of isotonic fluids, but not a very large one, let's just say, you know, because the very large impact, you know, was either the guideline or the Hawthorne effect of being observed and joining a QI collaborative. And that paper, is in preparation right now. Whew. Okay, so I managed to get through through all of the projects by 11:45, which was my goal. and I just want to take a moment to sort of synthesize both what we've learned and the current landscape of QI, inpatient QI, and pediatrics. Currently, these are projects that are in progress for VIP. A project called BASIC, which is Better Antibiotic Stewardship. This project is just launched. This is another, composite measure project with a focus on antibiotic stewardship across multiple diagnoses. Revise 2, which was the febrile infant project, is actually scheduled to launch very soon with an AAFE febrile infant guideline, which is really going to be published this time, we are assured. We are still embedded within the AAP and quality structure. And so we still try to prioritize, launching guidelines, particularly because the guidelines, tend to go through a very rigorous evidence-based review process. And so we're hopeful for that to launch in February or March. And then the project in development is on the use of high-flow nasal cannula in bronchiolitis. And this project will launch in fall 2021, when we all assume bronchiolitis will be back in force. So that's just a snapshot of the future. There's two things that I just want to mention, that are in progress, that are kind of interesting ideas to throw out there in case there happen to be any young investigators in the audience that are thinking about projects. One of the things that has come up from many of our sites is their relationship with their referral base. We're changing in the hospital, but what if our referral base isn't changing? We moved out to engage the emergency department, in change, and have been really successful and really excited about that collaboration. But what about our general pediatric colleagues? And so we have one site. It's a freestanding children's hospital, actually, which has been in VIP from the very beginning. So they have, data going back they even have data going back to 2008. And what they've done that no one else has really done is engaged really directly with their referral base. They sent them letters with each of their project participation that said, hey, we're participating in a QI project that is focused on using the AAP bronchiolitis guideline to improve bronchiolitis care. We understand that you may be sending us some patients, in which you're using some of the things that the guideline doesn't recommend. And we just want to talk to you about that. We want to acknowledge it. We want to say, we're not here to badmouth you. We're not here to say you're providing bad care. And they made some distinctions about inpatient care. And then they sort of followed, what the referral base was doing in terms of the proportion of patients sent into this hospital that were receiving bronchodilators over time. And this is just a statistical process control chart of that measure from 2012 to 2018. So it's a really long time period that they were collecting this data. And this is with the timing of their participation in bronchiolitis collaboratives, noted by the arrows. You can see that the mean use of bronchodilators was about 60%, and in the first time period. And then, by the end of after 2 collaborative participations and 2 rounds of communication with their priority base, it had decreased to about 40%. This is just an interesting observation and potentially some indirect evidence that inpatient quality improvement is having an impact on outpatient outpatient usage as well. And then, another thing we continue to do that I'm really excited about and engaged in is sort of continue to talk to our participants about their experiences in each of our projects and in what they're learning and how they're feeling about these things. Over time, this has allowed us to develop sort of some hypotheses around the idea that deimplementation quality improvement, or quality improvement that's intended to decrease non-evidence-based or overused practices, is a little different than quality improvement that's intended, to increase the use of a therapy or a test. We've been in the process of sort of evaluating this and trying to put it into the framework of some cognitive psychology and some behavioral economics. And some of the things that we've heard people say is that, you know, in order to give up an established practice, they really do have to go through the process of dealing with certain feelings. And those feelings, you know, sound a lot like fear and loss in the interviews. And the other thing that people, you know, have really pointed out to us is that that in general, medicine is subject to action bias, and you know, anytime you can reframe a change that is intended to de-implement, you know, in an action-oriented frame, that makes it a lot easier. So all of these things are helping us, you know, learn to design our next set of interventions. So in the last couple seconds, you know, I want to just talk a tiny bit about the challenges ahead, or the challenges in general for inpatient quality improvement, particularly as it applies to the large number of places that children receive care in the U.S. You know, what do we need to keep it going? You know, we need the guidelines. We need really good measures that are evidence-based and nationally sanctioned. And I think guidelines are a little bit endangered in the U.S. And I just want to put in a plug for anybody: when you pay your AAP dues, you know, to some degree you're paying for the guidelines. You're also you know, whenever people ask for priorities, you know, I think that the guidelines are a huge priority, and these things are hard to do and expensive, you know, in that there's a lot of volunteer work that goes in, but there's still also a lot of work on maintenance and upkeep. We also need to understand how to do QI in low volume sites. And we need those sites to keep participating. You know, I'm sure that most people are aware that a lot of lower volume pediatric sites are in danger in the US right now. You know, some people are closing down their pediatric efforts. And then those that have the luck of being affiliated with an academic medical center, like many of them at Stanford, you know, they really need your financial support to do these kind of projects and to participate. In terms of quality measures, I would also say that there's really a dearth, you know, of overuse measures related to quality. And this is from an evaluation that we did, and that Alan participated in, where we looked at all the nationally sanctioned, nationally promulgated quality measures and just classified them as to whether they were related to underuse, overuse, or misuse. And I've circled the part I wanted you to pay attention to, that 77% of our quality measures in pediatrics at the time we evaluated them were related to underuse of care, you know, and only 13% were related to overuse. And we just didn't feel like that accurately represented the state of the problem, you know. I'm actually going to skip this because I think I'm going a little long. So but I will put in a plug for people to look at this paper by Jay Berry, which is an evaluation of whether or not we have enough volume to even see a difference for a lot of the things that we're currently measuring in quality improvement in the U.S. And I think that you'll find the answer a little disturbing, you know, because it's mostly no. So ultimately, I'm going to end with a couple of thoughts. You know, children's quality priorities really are not just adult priorities applied across a younger population. I think in a lot of children's hospitals within a larger hospital or community hospitals, you know, this is just sort of assumed, and it's really hard to get the ear of the leadership in these hospitals. And so freestanding children's hospitals really need to make sure that it doesn't go that way, that it keeps happening. They're doing great research and they're doing great work, but their engagement with care across the full spectrum of where care is delivered is really what's going to drive quality improvement. So that's my plea for freestanding children's hospitals to stay engaged with this. And I think now I have my final 5 minutes for conversation or questions.
Thank you, Sean. That was outstanding. I just, what I love about all of your work on this is just how grassroots it has been in engaging so many people who are hungry to get engaged, particularly community hospitals, but really have not had opportunities to do that on the national level. So you guys have really provided that opportunity, and that's just incredible. So the question from Jesse Allen, actually, who thanks you, and by the way, I've received several texts voicing their enthusiasm for the talk as well. asking what you think the next area of overuse that pediatrics should focus on. Broad question, but an important one. What do you think?
Well, you know, so that is, you know, one of those things where we, you know, we sort of talk about this, and you try to be analytical on it, you know, and look at it, as well as try to talk to people in, you know, in practice sites about what are their priorities. And I think some of it depends on some of it depends on the population, and some of it depends on, you know, things like commonness and costliness. Clearly, we've thrown our lot in with high flow nasal cannula and bronchiolitis. You know, I think you're going to see quite a bit more research coming out in the next year. You know, but not done, you know, during the pandemic, because we've had a low volume of this care, but showing that high flow nasal cannula is a driver around a lot of overuse trends that we're seeing. And this is going to be interesting over time. So I feel pretty strongly that high flow nasal cannula is an overuse therapy that's costly and not providing much benefit for a lot you know, of our patient population. You know, I think for people who are doing newborn care, you know, something that's on the horizon that I'm really excited about is the new jaundice or hyperbilirubinemia guideline, because I also think that there's tons of evidence that, you know, we have overuse, you know, of phototherapy, you know, in jaundice, and that's going to be an important guideline coming.
There's a question that came in on the chat. Thank you for the excellent talk. I would love to hear more about the difficulty that low volume sites had improving care, and if we can tease out how much of it is due to measurement difficulty.
Yeah, well, so I think the low, you know, so some of it is probably related to, I mean, the measurement difficulty in terms of, you know, understanding if a change is an improvement when you really can't be sure, you know, based on low volumes. And that is for sure true. We aggregate the data, you know, and this is, you know, one argument in Jay Berry's paper. We aggregate the data to be beginning to see a local global picture, but that doesn't solve your problem locally. You know, so what do people do? You know, I think the other side of that question, you know, is the question around, you know, making change in an outcome when you know, the clinical care is fairly rare, you know, and so, you know, you're working on febrile infant in an ER, and potentially, you know, your febrile infants are a couple of months apart. And, you know, the physician taking care of the first one isn't the physician taking care of the second one, and those types of things. And that's really tough. And, you know, it becomes a question of how, of where that care is best provided, and also by whom, you know, is that care best provided? And I think that's one that I can't answer. I do think that we can help solve the problem, you know, of you know, providing the resources for those sites for what constitutes a pathway, what constitutes best practices, and providing the resources for measurement, you know, in at least on the aggregate. But we're still working really hard on the question of how we solve, you know, change, you know, in how we bring those people into the fold.
This last question, we have 1 minute left, is I think going to be right in your wheelhouse. You can, and I should have asked you to give all of your answers in the form of a question, by the way. But anyway, I missed that opportunity. But the question is, can you recommend any books or resources tied to behavioral economics and healthcare?
Oh man, can I ever? Actually, I have a whole talk about this.
We're gonna have to have you back, I guess.
Yeah, no, I mean, you know, so actually, you know, one of the best, well, I mean, I'm sure that most people have probably read Thinking Fast and Thinking Slow, I hope, by Daniel Kahneman, which is, you know, sort of the sort of seminal explanation. But I'm going to take this opportunity to promote a book by Doug Huff, who is a business professor here at Hopkins, and it's called Irrationality in Healthcare. why, and I just had to look it up for the subtitle, What Behavioral Economics Reveals About What We Do and Why. And so it's Doug Huff. This is a fantastic book. And he's just a really terrific guy. And the book is really just a sort of a global overview of behavioral economics perspectives, how they apply to each element of healthcare. So there's a patient perspective, a provider perspective, and sort of a system society perspective. And I really think this is a terrific book for healthcare providers to get an understanding about, about these things. And then, of course, I could talk for hours about all the other, people doing work in this area that I love that are terrific. Peter Ubel has great stuff, and I think Peter Ubel's at Duke, physician, also health economics researcher. Dan Ariely, also at Duke, writes terrific popular stuff on this, and so many more. Just send me an email and I'll give you like 15 books.
Thank you so much, Shawn. This was really an enlightening talk and an inspiring one. I hope folks can take some of these lessons to heart, and maybe we'll have you back to hear about behavioral economics in the next few years. Thank you so much.
Thanks, Alan. Thanks, everyone.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.